So I suppose we may start. So good afternoon. We are moving from the MDS field to the MDS-MPN field. And we start with Raphael Itzykson. He's a professor of hematology at the University of Paris and is working at Saint-Louis Hospital. I think he is connected, so we will be able also to have question and answer. Raphael, the floor is yours if you can hear me.
I do hear you. Thank you very much, Eric, for the kind introduction. I am awfully sorry that I am not being able to be amongst you in Kyoto. I hope you had a great meeting. Indeed, I work at Hôpital Saint-Louis. I'm particularly interested in the field of clinical trials in chronic myelomonocytic leukemia. Hello, everyone. My name is Raphael Itzykson from Hôpital Saint-Louis, and I'm very sorry that I could not make it to be with you in Kyoto for this wonderful regional symposium on myelodysplastic syndromes. I will discuss some recent aspects on the management of patients with chronic myelomonocytic leukemia. These are my disclosures. So we will discuss three aspects. There are a bunch of new diagnostic criteria for CMML. How is that going to change our practice? What is the role of allogenic hematopoietic cell transplantation in this disease? And in patients that are not eligible for transplant, what is the role of hypomethylating agents? So new diagnostic criteria. You are very well aware that in recent years, we have switched from FAB, then WHO classifications, to now two concomitant diagnostic classifications, the WHO and the ICC classifications. I will focus on the recent revision of the WHO classification. CMML is still the dominant entity amongst overlap mixed myelodysplastic myeloproliferative syndromes, and the prerequisite criteria have evolved in that the persistent monocytosis has changed in two ways. First of all, the threshold for absolute monocytosis has dropped from 1 gigs per liter to 0.5 gigs per liter. And second, the relative blood monocytosis has been reintroduced to compensate for the lower absolute monocytosis count. The other diagnostic criteria have not changed. Obviously, you need to rule out acute myeloid leukemia, so fewer than 20% blasts, and CMML is still regarded as a default entity, so you need to exclude, obviously, other CML, but other myeloproliferative neoplasms. And all of these prerequisite criteria must be met. The full workup of CMML seems not to have changed with complete blood count, peripheral BM, aspirated biopsy, karyotyping, and molecular genetics. So the introduction of this lower absolute monocyte count is the consequence of recent work initiated by Peter Valent and others 5 years ago, roughly, considering the fact that actually in healthy individuals, the largest amount of monocytes one can have is closer to 0.5 than 1 gigs per liter, even in older individual. It was then recognized by a number of works, I'm quoting here the Spanish works, but other have had the same conclusions. People comparing CMML to these so-called oligomonocytic CMML patients with 0.5 to 1 gigs per liter absolute monocyte count have shown that these patients, when they have the other criteria for CMML, such as dysplasia or cytogenetic or genetic alterations and so forth, really have the same genetic spectrum as full-blown CMML and still have a very poor prognosis. The recent WHO criteria still subdivides CMML based on the 13 gigs per liter white blood cell count threshold that we have found to be very helpful to differentiate myeloproliferative from myelodysplastic CMML, and it has simplified the blast cutoffs, removing CMML 0 and only considering patients with fewer or more than 10% blast in the bone marrow. And I think a large part of that is because it is difficult to standardize bone marrow blast enumeration in this disease due to their variable differentiation status. So obviously, you need to support your diagnosis with dysplasia. Here I display dysplasia along all three lineages that can be seen in CMML. Remember that monocyte dysplasia is difficult to find and is not always present in, at least under the microscope in CMML. And acquired clonal cytogenetics or molecular abnormalities, a handful of those genes are found in virtually all CMML patients. An important addition to the revised WHO criteria is the specific mention of peripheral blood monocyte flow cytometry and the abnormal partitioning. This is the consequence of a flurry of work that has been conducted by Oriane Wagner-Ballon and Dorothée Selimoglu over the last 10 years, where they studied the repartition of so-called classical, intermediate, and non-classical monocytes in the peripheral blood of CMML patients using these two very simple markers that are CD14 and CD16. And they found that accumulation of so-called classical monocytes beyond the threshold of 94% is really able to discriminate CMML from healthy individuals or individuals with reactive monocytosis with excellent specificity and sensitivity. And since the publication of that work that has been licensed, at least in Europe, we have had a large number of independent confirmations that this abnormal partitioning of peripheral blood monocytes is really independent of absolute monocyte count, cytogenetic lesions, white blood cell count, or blast percentage. It is also stable over time in patients that are not treated, and thus is a robust diagnostic criterion. Interestingly, this partitioning can be reverted by hypomethylating agents in patients that are responding to these agents. Finally, the biology of these sort of blocked monocytic differentiation has been worked up extensively by Dorothée Selimoglu-Buet, and it's not in the scope of this presentation to delve into the specifics of the epigenetic regulation of monocytic differentiation that is actually impaired in CMML. Again, this inclusion of these flow cytometry of peripheral blood monocytes in our routine diagnostic workup is supported by a number of independent validations, and there is a current effort in Europe to standardize this flow assay. And it also is relevant to patients with oligomonocytic leukemia, able to identify those patients that were previously classified as MDS that behave as bona fide CMML. So in patients with more than 1 gigs per liter monocytes, you only need one supporting criteria amongst dysplasia, acquired cytogenetic lesions, or abnormal flow to support the diagnosis of CMML. If you only have 0.5 to 1 gigs per liter, you need 2. There is the same feeling in the ICC 2022 that we should lower monocyte count to 0.5 and account for abnormal immunophenotype of CMML. And this is really what is the only difference in the ICC 2022 is the use of a 10% allele frequency cutoff to identify patients with cytogenetic lesions and identify a subgroup of patients that have so-called clonal monocytosis of undetermined significance, where the cytogenetic lesions is present at a lower variant allelic frequency. So these are diagnostic criteria. Remember, it should not serve for prognostic purposes. We now have a flurry of validated prognostic scores in CMML, some using molecular genetics, some not. I tend to like the CPSS just because it's so close to our good old IPSS for MDS, for risk categories, and really no evidence that amongst the prognostic scores that are blinded to molecular genetics, one supersedes another. So obviously we don't have this comparison yet for molecular-based prognostic criteria. So with these new prognostic criteria, one can wonder what is the role of allogeneic hematopoietic stem cell transplantation in these patients. And I would just like to remind you that CMML is not just MDS. And these are recent data from the European Bone Marrow Transplantation Registry showing that patients with CMML that are transplanted are actually faring more poorly than patients with MDS. And this is really caused by an increased risk of relapse after allogeneic stem cell transplantation, not so much because of a difference in non-relapse mortality. So this is really a specific disease that requires a specific post-transplant strategy to mitigate the risk of relapse. So a few years ago, along with colleagues from the International Working Group on CMML, supported by the MDS Foundation and the European Bone Marrow Transplantation Registry, we tried to pull up a retrospective analysis to try and identify those patients that benefit from upfront transplantation. We chose to focus on patients younger than 70 years of age, diagnosed and transplanted between 2000 and 2014 with adequate follow-up. And to make a long story short, because obviously when you're doing this kind of retrospective analysis, you have a number of statistical biases. But even using very simple univariable time-dependent analysis, it appears that patients that have lower risk disease based on the conventional, again, molecular agnostic CPSS score, so patients with low or intermediate risk, intermediate 1 risk, really have no benefit of allogeneic stem cell transplantations, whereas in patients with higher risk, it is difficult by univariable analysis to really call for sure for a benefit for allogeneic stem cell transplantations. So we turn to multi-state models to try and better study the outcomes of these patients, and this is the kind of prognostic model that you can get for a given patient of a given demographic and CPSS risk. And when comparing scenarios predicted by this multi-state model, it did appear that male patients with higher risk CMML, regardless of age, would benefit from upfront allogeneic stem cell transplantations, but not lower risk patients. The signal for female patients in that study was not as strong, and it is not clear whether this is due to differences in biology or patient populations, or just because of statistical power, because this disease is much more frequent in male than in females. So to summarize what we currently know of allogeneic stem cell transplantation in this population, there's really no benefit for early allogeneic stem cell transplantations in lower risk patients. The benefit of higher risk in higher risk patients is more pronounced in males. Retrospective studies are subject to numerous biases, and thus we need new studies to account for genetics and alternative donors in this difficult to treat disease. So finally, what is the role of HMAs in patients that are not eligible for transplant? We have a sort of meta-analysis of 17 studies showing an overall response rate close to 50%, but with a lower complete response rate. And we know that HMAs do not blur the adverse prognosis of patients with myeloproliferative CMML, no true difference between azacitidine and decitabine. And the question we were wondering was whether in patients with myeloproliferative CMML, the use of upfront hypomethylating agents could confer a survival advantage over hydroxyurea. And thus we run the European randomized Dakota trial, which is a recent randomized phase 3 trial in patients that have both myeloproliferative disease, but also advanced disease based on bone marrow blast excess, cytopenias, extramedullary disease. And these patients were to be not eligible for transplant and previously untreated except for a short course of hydrea before accrual in this study. And these are really old patients. A large number of them had CMML2, 1/3 of the patients, and they were really myeloproliferative with a median white blood cell count of around 30 gigs per liter in the two arms of the study. And with a median follow-up of 17 months in patients receiving a median of 5 or 6 monthly cycles of decitabine or iduria, there really was no difference in the primary endpoint of event-free survival in the trial, nor was there in terms of overall survival. And this was not due to patients in the iduria arm switching to HMA after failing to respond or progressing, because censoring at HMA onset did not really change the lack of difference between these two groups. Neither did we identify, a clinically defined subset of patients that would significantly benefit from decitabine over hydroxyurea. And this is in spite of the fact that the true rate of complete remission was obviously higher, but still low in the decitabine group compared to the hydria group, because only roughly 12% of patients actually achieved a bona fide complete remission with single-agent HMAs. And indeed, we found that there was a reduced incidence of progression or AML transformation in the decitabine arm, but this was mitigated by a higher risk of death without progression or transformation in that same decitabine arm. So we are still running correlated biomarker studies in the Dakota trial, but we do need to progress in terms of translating the superior response rates of HMAs into meaningful survival benefit in proliferative CMML. And we must bear in mind that CMML patients are frail even when they're not neutropenic, and we need to optimize HMA-based combinations with new targets. Very recently at ASH, our eyes were turned to HMA plus venetoclax, because this has proven an interesting association in AML and hopefully in MDS. We have seen interesting trends in terms of overall response rate in a retrospective US study, with an overall response rate against moving to this 40 to 50% overall response rate to 90% of responses, but these were mostly blast clearances in the bone marrow rather than recovery of cytopenias, and thus the CR rate modestly increased, and that did not translate into improved overall survival. Hopefully, we have new targets around in CMML that includes targeting the GM-CSF receptor with lanzulimab, targeting the signal transduction cascade below that, including through inhibition of JAK-STAT signaling. So I hope in the future we have better drugs and drug combinations in that disease that I believe remains really an unmet medical need. And with that, I would like to thank you for your attention and thank my wonderful colleagues at Hôpital Saint-Louis, GFM, FISM and German MDS group, regrouped into the EMSCO, Gustave Roussy Lab, and the EBMT for the wonderful collaborations in that landscape over the last years. I thank you for your attention.
So this is, the paper is open for discussion.
Okay, hello, Raphael. This is Eva Hellström. Thank you very much for your talk. I have two questions that are more diagnostic. One is that many patients with lower risk MDS, like our CMDs or so, with time achieve a higher monocyte count. So if you have a patient with a TET2 mutation and an ordinary RCMD, and that patient survives for 4 or 5 years, that patient will very often get an increased monocyte count, which is in particular problematic since the cutoff was lowered. What do you think about that? I mean, you don't rename them just because they get 0.6 in monocytes.
So thank you, Eva, for this question. So to be fair, I was not really part of the groups that coined this definition of oligomonocytic CMML. And I do agree with you that we see that. I think we understand this phenomenon from a pathophysiological standpoint. I really think diagnostic classifications should be used at diagnosis. And we have to bear in mind that what we need to use along patient evolution are mostly prognostic stratifications rather than anything, none of which is really developed in a time-dependent manner. And it's interesting to see that in CMML, I mean, in most recent prognostic classifications, absolute monocyte count is not considered as a poor prognostic factor. It's really the whole white blood cell count that matters, and that probably means that additional cell populations beyond morphologically defined monocytes contribute to the poor prognosis of CMML patients, but I'm sure Eric will develop on that. So to make a long story short, I wouldn't change my classifications for those patients, and I realize that in my routine practice there are some of these patients for which in my medical report for every other outpatient visit I will call them CMML or MDS. I think in terms of management for these lower risk patients it doesn't change much, and I am convinced that this slow increase in monocyte count simply reflects the expansion of the TET2 clone within the hematopoietic stem cell pool. We showed years ago with Eric that these TET2 HSCs are slightly biased towards the monocytic lineage at the expense of erythroid differentiation. So it really makes sense that as years pass, this TET2 HSC pool expands and translates into these slight, I think not clinically significant changes in the monocyte in the blood cell repetition. That said, given the tantamount knowledge that we now have on the impact of these TET2 HSC clones on non-hematopoietic outcomes, I really think we should delve into deeper details as to what are the events that these patients experience over years beyond progression to AML or progression of cytopenia.
Yeah, thank you.
Professor Miyazaki.
This is Yasushi Miyazaki. Thank you very much for your very nice talk. I have a question regarding the clinical response part. In Dakota trial, HMA increased the complete remission rate and overall response rate. And if you add venetoclax, the response rate went up to more than 90%. However, in both studies, there was no improvement in terms of overall survival. How do you think about the role of complete remission in terms of the response criteria?
Okay, this is Professor Miyazaki. This is a great question. I can give two short answers. I think if we have the classic reasoning about what we can leverage from complete remissions in this high-risk disease, as in like TP53 mutated MDS or AML, it's in terms of transition to allogeneic stem cell transplantation. And we are currently running a phase 2 trial of venetoclax plus azacitidine in France, and we really consider this regimen as a bridge to transplant, which brings us back to the feasibility of allogeneic stem cell transplantation in many patients. And then the other part of the question is obviously, I fully agree with you that we need better landmarks than the current response criteria. And Dorothée Selimoglou-Buez and Eric Solary's lab is pursuing currently, I think, a very important work looking at the flow cytometry evolution of patients in the Dakota trial. And I would be very interested to see whether we can leverage these flow cytometry correlative analysis to design novel, innovative response criteria that do translate into meaningful clinical survival benefit.
Thank you.
Yes, please.
Thank you. So hi, I'm Dr. Yao from National Taiwan University, and I have a question about the diagnosis of CMML. So specifically about how you define the boundaries of the gate that define the 3 monocyte subsets. Because I tried to look into those papers, but I don't think I had read about a very clear-cut answer. For example, in some of those papers, the upper boundary of the ML1 is horizontal, and in some of those papers, the line is like tilted, and if you tilt that line upward a little bit, maybe you get more classical monocyte percentage. But then, does that make this patient more probable of being a CMML patient? So I have a little bit of doubt in that. So do you have any recommendations on how we can draw, how we define the boundaries of those 3 gates on the flow cytometry 2D plot? Thank you.
This is a question that, to be fair, I cannot fully answer. I am probably lacking courage, but I must say that in France, people that treat patients are not the ones who perform the diagnostic workup. So we have experts, hematologists, biologists who do that. So I have to trust them. And it is my understanding from discussing with them that they have performed this sort of multicentric validation, that indeed it requires, as I think for any flow cytometry approach, including in AML or in MDS, it requires shared expertise. So you have to train with someone else. That I understand is a caveat to the multicentric development of the assay, but I think it has still been nicely ongoing, at least in France and in Europe, in terms of standardization. So, short answer is I'm not sure. I'm not sure that by myself I would be able to put the gates properly, but I'm pretty sure that once you've trained with someone who is familiar with the assay and you're part of these standardization networks, then you can achieve some level of strong reproducibility. Yeah.
Thank you very much, Raphael. I don't see any other questions, so thanks a lot for being connected, and have a good day.
Yeah, I will. Be happy to follow on this section.
So next speaker is Dr. Eric Solary. As you all know, he has been the leader of the field. And Dr. Solary will give us a lecture on molecular pathogenesis aspect of CMML. So Dr. Solary, please.
Thank you very much for the introduction. I am very grateful to Seishi for his kind invitation and for all of you in the MDS Foundation for organizing this meeting. Thank you. Well, I suppose I have to go there. These are my disclosures. So I will not go again through the diagnosis criteria. MDS is not CMML, or CMML is not MDS. There is no conflict between ICC and WHO on the definition of this disease. And in addition to the criteria that have been mentioned by Raphael just before, I can add that both WHO and ICC still recognize the proliferative and the dysplastic form of the disease with a cutoff value of white blood cell count to 13 giga per liter. And also a distinction between CMML1 and CMML2 based on the blast count. So this diagnosis is relatively simple, but in contrast to that, the disease itself is highly heterogeneous, both clinically and biologically. As you know, some cases are associated with autoinflammatory reaction, others are combined with systemic mastocytosis and so on. Oh, sorry. I have to go in the other way. And this probably also explains the difficulties in the CMML patient stratification, and many different score systems have been generated along the years, and Raphael mentioned them, but no one is doing better than the other. So probably we are missing something in understanding this disease. So what I am going to discuss today is what are the disease common features among these heterogeneous aspects, and which additional stratification parameters could be used to help us to better understand how these patients are going to evolve. And maybe this could generate new ideas in terms of therapeutic strategy. So the first unifying features of this disease is that it reflects an accelerated aging of hematopoiesis. And to support this assertion, what I want to show is first that when we perform whole genome sequencing of the DNA of sorted monocytes of these patients, we always identified a signature of aging, and usually 2 signatures of aging, except in 2 cases with a signature in red in these 2 cases, but these 2 cases are CMML developing in patients who received before chemotherapy, one for a solid tumor, another one for a non-Hodgkin lymphoma. In all other cases of primary CMML, you get only signatures of aging. That's the first point. The second one is if you look at gene expression in monocyte, you have a signature of aging in the monocyte of everybody. And this signature is made in part of pro-inflammatory genes. And if you looked at the signature of the gene expression in the monocyte of patients with CMML, this is just an amplification of this aging-associated signature. This is the second point. The third point is when you looked in CD34 positive cells, you probably are aware that one of the characteristics of aging of hematopoietic stem cells is the decrease in the expression of this histone mark, H3K9ME3. And in patients with CMML, this decrease in the expression of the H3K9ME3 is still amplified. So we have at least these 3 characteristics that demonstrate that CMML pathogenesis may benefit in the future from the rapidly growing understanding of aging biology. And we have to follow carefully what is happening in the biology of aging in clinical trials now that emerge trying to reduce the effect of aging, that could globally learn us a lot on how to reduce the aging of the hematopoietic tissue. The second unifying feature of this disease is a strong epigenetic component. As you all know, there is a variety of abnormal DNA methylation patterns that have been described in the cells of these patients that are more or less correlated to the genetic abnormality. This is a first aspect. The second one is that when we looked at the mutation in the sorted monocytes of these patients treated with hypomethylating agents and who were in complete response. As you saw with Raphael, it's not so frequent, but you can see patients with a complete response to hypomethylating agent. And we looked at the viral allele frequency in the cell of these patients, and they were exactly the same as those observed at diagnosis or before treatment. So meaning that you have a strong impact on the phenotype of the disease just by inducing demethylation of the DNA without having any change in the genetic background. And even more, we saw in some cases patients demonstrating a genetic evolution during treatment while they were in complete remission clinically and biologically. And so in this patient, we saw genetic evolution leading at the end to AML transformation while they were still under treatment with hypomethylating agents. The third aspect was already discussed by Raphael. We describe this abnormal partition of monocyte subsets in the peripheral blood that is now one of the criteria to support the diagnostic and can help you to rapidly distinguish reactive monocytosis from a CMML in a few hours. And the mechanisms of this abnormal partition has been deciphered by our group, and what we showed is that it is an epigenetic deregulation of a microRNA 150, that in turn deregulates the expression of TET3, not TET2, TET3 in the classical monocytes, which prevents the maturation of classical monocytes into intermediate and non-classical monocytes. And if you get a response to hypomethylating agents, the characteristic features in that you restore the normal repartition of monocyte subsets in the peripheral blood of these patients. This is another argument to think that there is a strong epigenetic component in this disease. And last, what we observed recently is that another histone marks that we studied is H3K9M2, not 3-2. And what this mark is really increased in the CD34 positive cells of this patient. So we have a kind of signature with a decrease H3K9 MS3, an increase H3K9 ME2, which is a characteristic pattern of histone mark in the hematopoietic stem cell of these patients. So CMML pathogenesis for sure includes a therapeutically, an epigenetic component that is already therapeutically targeted with hypomethylating agents, but maybe could be further targetable with, by targeting other mechanisms of epigenetic regulation. The third unifying feature of this disease is an intrinsic proliferative component. That was well described by Eric Padron a few years ago, and this is translated by the hypersensitivity of myeloid progenitors to GM-CSF, as described this morning in CMML. And this can be measured, for example, by looking at the phosphorylation of STAT5 in the granulomonocytic cells. And what is important to consider is that this proliferative component also exists in the form without accumulation of white blood cells. So this is really an intrinsic hypersensitivity of myeloid progenitor to GM-CSF. Of course, it is amplified in the proliferative form with RAS pathway mutation, but it also exists in the so-called dysplastic form of the disease. So the MPN component is not considered currently in the therapeutic, in the clinical trials that are designed or developed in this disease, because usually CMML is still frequently associated with MDS, high-grade MDS, but actually we should consider this component to better take care of our patients. And finally, what we showed with Raphael 10 years ago by analyzing the clonal architecture of this disease is that in many cases, the number of residual Y-type cells in the bone marrow is very low at the level of the stem cells. So in many of these patients, most of the stem cells are mutated. So this early clonal dominance has to be considered in therapeutic objectives. So we are facing a disease of aging with a proliferative component that we might consider better, with, for some reason that we do not explain, very rare TP53 and UBA1 mutations. That's a specificity of this disease. Very few residual Y-type stem cells in the bone marrow, and an aging hematopoietic tissue and an aging bone marrow niche. So could we improve disease stratification and suggest alternative therapeutic strategies? One of the population of cells that we analyze are the immature myeloid cell circulating in the blood. This IMC count has not been included in most CMML stratification so far. And we still verify that with Mrinal Patnaik at the Mayo Clinic in Rochester. In his database, he has 580 CMML patients, and he looked at the prognostic value of IMC. And of course, in univariate analysis, it is a prognostic factor, but in multivariate analysis, usually this prognosis factor disappears. So to get more insight about this population of cells that can appear in the peripheral blood, we use spectral flow cytometry. And by this spectral flow cytometry, we were able, here below in red, so you can get access with this combination of markers to all the circulating blood cell population. And focusing on granulocytes that are on the left below, we identified an abnormal population of immature granulocytes here in red that express CD15 but express low level or no CD16. And so we learned how to quantify this population, and we did that prospectively for many years now. And so we identify a population of patients with a high count of these immature granulocytes that we call IGRAN, and the phenotype of this population is indicated on this slide. And what we observed in this learning cohort is that this IGRAN is a strong prognostic factor, and this was validated in a second cohort of 160 CMML patients. So the presence of immature granulocytes detected in the peripheral blood with a cutoff value which is 14% of CD11b positive, CD33 positive cells. So again, we have to be very precise in the way we quantify this cell population. And by using this criteria, we improve the outcome. Then we try to understand what were these cells and why they have such a prognosis impact. And the first thing is that these cells are behaving as myeloid-derived suppressive cells. They belong to the clones. They express the same mutations as those detected by whole exome sequencing in sorted monocytes. So if you sort these cells, you find the same mutation as in monocytes. No new mutation. It's not a subclonal evolution that generates these cells. And if you looked at this experience, when you co-incubate activated T cells with PBMC of these patients, you generate some effect on the proliferation. If you deplete this IgRAN, you increase the proliferation of T cells. If you add sorted IgRAN to this population of PBMC, you totally inhibit T cell population. So they are suppressive. So these cells have a suppressive effect. That's the first point. Another aspect is that we detected that they were able, in the patients that have a high level of this immature granulocyte population, they produce and secrete a high amount of IL-8, CXCL8 cytokine. And so we looked at the impact of this cytokine on the CD34 positive cells. And what we observed, and here we tested cord blood CD34 positive cells, adult healthy donor CD34 positive cells, and CMML CD34 positive cells. And we incubated these cells with CXCL8. In this case, we use colony semi-solid medium to calculate that. And what we observed is that the cytokine is able to inhibit the growth of wild-type cells, but has no impact on the CMML CD34 positive cells. So why? But because, again, epigenetic is downregulating the expression of the two receptors of CXCL8 at the surface of CD34 positive cells of CMML patients. So by this, what we get is that IL-8 is able to produce by immature granulocytes, or by granulocytes of patients with a lot of immature granulocytes. They are able to inhibit the growth of wild-type hematopoietic stem cells, and they have no impact on the growth of mutated cells, giving a growth advantage to these mutated cells. And as we could not develop a mouse model to verify this hypothesis because CXCL8 genes is not expressed by mice, we use a mathematical model to try to understand the impact of CXCL8 on stem cells. And then if you calculate the growth rate and the proliferation rate of the cells and use these parameters for this mathematical model, what we observe is that adding CXCL8 to a combination of mutated and non-mutated cells, CMML cells, what you gain is years and maybe decades of progression to the fixation of the clone. So this feedback loop between granulocytes and stem cells is increasing the progression of the disease. So what I just showed you is that in addition to helping the diagnosis, flow cytometry analysis of peripheral blood cells can help you to stratify the patients. And when you combine that with other parameters, it's still present in multiparametric scoring analysis. Then, Raphael just described the Dakota trial results, and we looked at inflammatory cytokine in the peripheral blood of the patients at the beginning of the treatment. And analyzing the level of cytokines as continuous variables, we were surprised to identify 7 out of 46 cytokines analyzed as being somehow predictive of the way the patients are behaving. So for some of them, we have at least partial biological explanation. For example, let's start with MIF, macrophage monocyte inhibitory factor. What we showed some years ago is that if you downregulate TET2 in a cell line, but it's true also in a mouse, if you delete TET2 in a mouse, you get an overproduction of this cytokine, MIF, macrophage inhibitory factor. which is interesting to correlate with cardiovascular risk, because MIF is the main cytokine involved in atherosclerosis development. So when you downregulate TET2, you have an overproduction in MIF, in cell line, as in animal, at the level of the gene, of the protein, and of the cytokine secreted in the medium in this case. And what we showed is that MIF overproduced by mature cells of the clones that have truncated TET2 is able to come back on the normal stem cells or mutated stem cells and push towards monocytic differentiation. So this is another forward loops that could participate to the disease development. Another one is tumor necrosis factor. What do we know about maybe this overproduction of TNF has to be connected with the frequent association of CMML with systemic mastocytosis. Actually, CMML is the most frequent hematopoietic malignancy associated with systemic mastocytosis. It's 20-fold more frequent than MDS, for example. And what Mrinal Patnaik showed some years ago is that surprisingly, it's associated with an increased number of deaths, but with no AML transformation. So maybe because the patients die before from the consequence of systemic mastocytosis itself. So it's not associated with the progression of the CMML, but it's poor prognostic factors. Then we wanted to know really how many patients have this KIT mutation characteristic of mastocytosis. And by using digital PCR, what we observe is that if we look in the bone marrow cells, you find this mutation in 1.9% of the patients. But if you look in the peripheral blood monocyte, actually the mutation is present in more than 12% of these patients. And why? It's probably related to the clonal architecture of the disease. Again, what I told you before is that the white-type cells are, residual white-type cells are very rare. And then in the stem cell population of these patients, you can still observe the linear accumulation of variants. And probably there is no competition at the level of the stem cells because you can still find these cells with 1, 2, 3, 4 mutations all living together. But then, when the cells undergo differentiation, there is a clear advantage to the most mutated cells. And this probably explains why, when you look in peripheral blood monocytes, you more easily detect the cases in which there is a subclonal evolution with a KIT mutation somewhere. So, and TNF was very recently shown in a blood paper to do the same as IL-8, actually, to be able to inhibit the growth of white-type cells and to keep the mutated cells growing due to the overexpression of BRCA5, so which prevents apoptosis. So TNF is another cytokine that could contribute to the fixation somehow of the leukemic clone. Another cytokine that was significantly increased is calprotectin, which is the heterodimer of two alarmins, S100A8 and S100A9. These alarmins are increasingly involved in the pathogenesis of MDS or MPN, but even through actually the mechanism of action is not so clear. So again, this calprotectin, even in multivariate analysis, remains an apparently strong prognostic factor. This has to be validated in an independent cohort. But what we observe by ex vivo analysis of the effect of calprotectin on hematopoiesis, we culture CD34 positive cells of healthy donors in the presence or absence of calprotectin or IL-6 or calprotectin and IL-6, and what we did in this specific experiments is that we use JAK2 mutated CD34 positive cells, in which in this culture without erythropoietin, you generate erythroid cells because of the JAK2 mutations. They are here in violin. So what we observe is that in the presence of calprotectin, you completely block the generation of erythroid cells, which is not the case with IL-6, but it's still the case with the combination of IL-6 and calprotectin. So calprotectin is specifically inhibiting erythroid differentiation, which we confirm also in the presence of erythropoietin in healthy donor CD34 positive cells. So calprotectin, which is overproduced, has a specific impact on hematopoiesis, which is inhibiting erythropoiesis. And actually, it appears to be a strong mediator of anemia, of inflammation. IL-6 is acting through the hepatocytes, but calprotectin is directly inhibiting erythroid differentiation at the level of the progenitors. And finally, the last I will describe is IGF-BP2, because IGF-BP2 is overproduced by the cell of the niche, actually, in this disease, and aging cells of the niche, and especially stromal cells, are producing a lot of IGF-BP2, which is increased in the context of CMML. And again, IGF-BP2 has some prognostic value. And what we observe is that if you put IGF-BP2 just on monocytes themselves, you promote a pro-inflammatory phenotype of these monocytes. So the niche is secreting a cytokine that increases the pro-inflammatory phenotype of the circulating monocytes, again contributing to this strong inflammatory milieu that characterizes the disease. So maybe we should target mature cell of the clone of CMML rather than trying to target the immature cells or the stem cells. And to find a way to target these mature cells, we analyze the apoptosis of peripheral blood monocytes of these patients. And what we saw is that in a fraction of patients, monocytes are resistant to spontaneous apoptosis. And we deciphered the molecular mechanism of that, and this is related to overexpression of MCL1 and the secretion of a cytokine, which is not very much known, and whose name is CTL1. And actually, it was very well studied in Japan. And this CTL1 is coming back on monocytes through CCR2 receptor, activating the MAP kinase pathway, and further promoting the survival of these monocytes. So by targeting this pathway, for example, with MCL1 inhibitor, but unfortunately, there are no more developed, this was discussed by Guillermo earlier, and MEK inhibitors, we could restore the apoptosis of CMML monocyte while sparing the healthy donor monocyte, actually. So to summarize, we start with a disease of the stem cells in which mutations accumulate, and this is associated with an abnormal epigenome and generates somehow a hypersensitivity of progenitor to GM-CSF, contributing to the proliferative part of the disease. But with that, this is a disease in which cell maturation is preserved, which sometimes we forgot to consider. And these cells that are generated, there are many properties that contribute to the disease development. The dysplastic monocytes overproduce, for example, CTL1, calprotectin, MIF, and I showed you that they can contribute to disease progression. The dysplastic neutrophils, they produce IL-8, calprotectin, and if we look at the niche cells, they also may contribute to the development of this very strong inflammatory milieu. So to conclude, the current stratification system may be improved, first by using flow cytometry quantification of peripheral blood immature granulocyte cell subsets, and also by measuring, but it's not so easy, inflammatory cytokine plasma level in the peripheral blood, probably also in the bone marrow, probably more difficult. The pattern of the elevated cytokine levels is modulated by genetic and epigenetic features of leukemic cells and by bone marrow niche cells, and may generate additional information for patient stratifications. And we have probably to identify different patterns of cytokine secretion that are specific for subgroups of patients. And at the end, mature cells of the clones or niche cells or the cytokine they produce are potential therapeutic targets to step down disease progression. And these strategies may be tested early in disease progression to prevent the emergence of RAS pathway mutations, JAK mutations that will make the disease more proliferative and more difficult to control. And with that, I would like to thank all the collaborators in the lab, especially Dorothy Selimo-Glubuet, that was a strong contributor, and thank you for your attention.
Thank you, Dr. Solary, for comprehensive and also very educational talk. Thank you.
Thank you.
Yeah, it was really fantastic. So I believe the H3K9 is a repressive mark.
Yeah.
So I have two questions, if I'm allowed.
Yeah.
So we, a number of years ago, generated two mouse models that we wanted for MDS, targeting H3K4 trimethylated, that is kind of a mark of activation, that is actually modulated through this other lysine modification through this Jumanji D3 KDM6B protein. So if you overexpress that, actually, these mice develop disease. That looks like actually CMML. And then if you cross the mice with TET2 model, they really have a proliferative CMML picture. So have you looked at H3K4 trimethylation status in these systems?
Not this way. Actually, what we saw is that this is associated with a strong mobilization of retroelement. This pattern of epigenetic marks is associated with the mobilization of retroelements, but we did not make any focus on this specific marks, which could be very interesting to look at.
Because maybe there's like a shift from one conformation. And then this is totally silly question. But I think we have a paper in press where we show very similar to you that, for instance, P53 mutations are rare in CMML. Yeah. But then, and the therapy-related CMML is also rare. But actually, when we compare the outcomes, even if you have quote-unquote therapy-related CMML, whatever that means, actually the behavior is pretty kind of normal. Basically, there's no difference between the therapy-related CMML and the normal CMML. So the question is, why will these cells be protected from these P53 mutations and this kind of impact from therapy? I mean, this was total random finding, and then we couldn't believe it. But there must be something that is protecting these cells from this kind of genotoxic effect.
Yes, for sure. We still don't know, but this is something we are trying to understand, and there are several possibilities. One also is another way of deregulating the pathway without having the mutation. So that's something we are trying to see whether it's possible and how it's possible. And that's one of the paths that we are exploring currently. We have no answer so far.
Thank you.
Thank you for a beautiful talk. So my question is about the GMCS hypersensitivity. So usually in the case of JMML, GMCS hypersensitivity is one of the criteria. So probably most, if not all, of the patient has GMCS hypersensitivity, and this is, in my understanding, it is related to the RAS pathway mutation. But in CMML, surely RAS pathway mutation is frequent, but not that frequent. But nevertheless, if those cells lacking RAS pathway mutation still shows GMCS hypersensitivity, this is one question. So GMCS hypertension is confined to RAS pathway gene mutated cases. This is one question. If not, what is the explanation of the GMCS hypersensitivity with those lacking RAS pathway mutation?
Oh, well, that's a very good point, of course. So for sure, the high level of hypersensitivity to GM-CSF is provided by RAS pathway mutation and sometimes JAK mutations or an alternative pathway mutations, but they are identified only in 50% of the patients, you are right. So in the other cases, it's not clear the mechanism that provide this slighter, not so hard, but nevertheless present hypersensitivity to GM-CSF. And so you can imagine that maybe some epigenetic mechanism is sufficient to make the pathway more sensitive, or you can activate intracellular signaling pathway by this way, which is not clearly deciphered. And what is, in my mind, significant is that when you take ruxolitinib in these patients, we have patients that answer and that are not necessarily RAS mutated, so it's not correlated to RAS mutation. So it's not only a matter of genetic background. There is something else that is generating this hypersensitivity, which today is not that clear, I would say.
Okay, thank you so much.
Last question, please.
So thank you very much for a very insightful talk. And based on your lecture, so I think each cell population has each rule in the CMML biology. But when we looked at the CMML monocyte, so can we think this way that CMML monocyte reflect the CMML primitive biology, such as CMML HSC, and reflecting or associating with the clinical features. So is it okay to think about that?
Well, thank you for this point. No, for sure you cannot summarize the biology of the disease to monocytes themselves. And actually what we are trying to generate years after years is a kind of atlas of the mature cell of the clone to understand the contribution of each subset of cells, of mature cells generated by the leukemic clone. what kind of cytokine they produce, and how it contributes to disease evolution. And I think that we might be able to have kind of vision of the contribution of mature cells. Then when I suggest that we could use a therapeutic strategy to control this inflammatory component, is that you are probably sharing this experience. These patients, what they say, what they transform in only 20 to 30% of cases in AML, and the others, what they do is that they accumulate fatigue along the years. They are more and more exhausted because of this rising inflammation generated by many different cell types. And if we were able to, well, that's the hypothesis, I have no proof of that, but maybe if we were able to control this inflammatory part generated by mature cell of the clones, we will not cure the disease. But these aging patients, if we improve their quality of life, they can live with a little bit too much of monocytes. They don't care about that. What they want is to improve their quality of life. And I think by targeting the inflammatory component, maybe we can improve their quality of life and reduce the risk of progression toward transformation. That's hypothetical at this stage, but that's another way of thinking about the disease.
So if not, we'd like to close the session if you agree. I mean, I should wait until you come back here, but can I close the session?